My name is Dr. Ellen Rourke. I've been a board-certified OBC-GYN for nearly 22 years, practicing in a mid-sized regional hospital in the Midwest. We handle everything from routine prenatal care to high-risk deliveries. I've seen my share of complications, triumphs, and tragedies. This isn't a job you do if you're afraid of hard truths. You deliver life, but you also sometimes sit quietly in the silence where life was supposed to be. That's the reality. This story isn't about a diagnosis or a medical error. It's about a pattern, a room, and a screen. Room 3, labor and delivery, East Wing. It's not a flashy room. It doesn't have the best window view, slightly closer to the nurse station than others, which made it convenient when we were short-staffed. But nothing stood out at first. The first time I noticed something off was in late November 2020. We had a 36-year-old G2P1 Danielle in labor with her second normal prenatal course, all labs clean. She was admitted at 39 weeks, spontaneous labor, favorable cervix. Everything looked fine. Until we noticed a sudden deceleration on the fetal monitor, bradycardia, down to 70 BPM and holding. No signs of abruption, no cord prolapse. I was in the room within 45 seconds of the call. We repositioned, gave O2, fluids, and just when we were prepping for an emergency C-section, the tracing corrected itself. Rapid acceleration, back to baseline. Strong variability. Baby delivered vaginally 3 hours later, healthy, 7 pounds even. But what caught me off guard was during charting. One of the L&D nurses, Melissa, was reviewing the fetal strip recording. She pointed at something, not the tracing, the corner of the screen. There, you see that? It was a shadow. Human-shaped, tall, unmoving, like someone was standing just behind the monitor. I assumed it was a reflection, maybe a staff member passing through, but she shook her head. No one was there. That angle, it would have had to be someone inside the monitor cart. We didn't think much of it then. Weird? Yes, but chalked up to screen artifacts. Maybe interference from the telemetry. Until it happened again. 2 months later, January 2021, another patient, 29-year-old, first-time mom, came in with decreased fetal movement at 34 weeks. NST was non-reactive. We admitted her for continuous monitoring. 5 hours in, a Category 3 tracing. We did everything by the book. Oxygen, side lying, fluids, even tried amnio infusion. Nothing helped. Crash C-section, no heartbeat on delivery, no spontaneous respirations. NICU tried for 18 minutes. No response. Fetal autopsy showed no structural anomalies. Cord was slightly marginal, but nothing that explained the loss. Again, we reviewed the strip for documentation. Again, that same shadow, same position, same angle, visible only on playback. This time it rattled the nurses. One asked to switch wings. The charge nurse submitted a formal request to stop using room 3 for high-risk labors, but protocol dictated rotation. When all other rooms were full, room 3 had to be used. The third time was April 2021. I remember this one vividly. 24-year-old patient. Came in for induction at 41 weeks. Textbook pregnancy. She was cheerful, calm, had her partner by her side. Monitoring was fine for the first 12 hours. Then sudden late decels, unresponsive to intrauterine resuscitation. We were in the OR within 8 minutes. The baby was delivered with no heartbeat. Resus team tried. Again, no response. That one broke the staff. The third stillbirth in that room in under 6 months. All without an identifiable clinical cause. I reviewed every chart myself. Every strip, every intervention, every second accounted for. Nothing missed. Except that shadow. There it was again. Playback only. Never live. The same faint silhouette near the monitor cart. Always in the same spot. Always still. We had biomedical engineering check the equipment. They found no malfunctions, no interference, even replaced the monitor unit, and hardwired the new one. The shadow showed up 2 weeks later, same room, same screen. So we stopped using room 3 for deliveries, converted it into a recovery overflow bay. No more monitors, no more laboring patients. We never told patients why, just called it a staffing relocation. But internally, we all knew. Even the night cleaning staff started refusing to go in alone. One of the techs said the monitor, when it was still there, would light up faintly at night, even unplugged. I'm not here to sensationalize. There's no haunting, no cinematic moment, just a pattern, one that left a mark. I've delivered over 3,000 babies in my career. I trust medicine. I trust science. But I also believe that hospitals, especially labor wards, hold echoes. Echoes of life, of loss, of what might have been. Room 3 isn't used for deliveries anymore. But sometimes walking past it, I still glance at that corner. The monitor's long gone, but part of me expects to see it flicker on. And that shape, just standing there, watching, waiting. Hello friends, and thank you so much for tuning in. A special shout out to our incredible subscribers. Your support keeps these creepy, fascinating, and sometimes even comforting stories alive. But here's something to think about. Only about 30% of our viewers are subscribed. If you enjoy our content, hitting that subscribe button helps more than you might realize. It only takes a second, but it makes a world of difference. While you're at it, a like and share go a long way in keeping these eerie tales coming. Thank you again for being part of this journey. You're the reason we're here. See you in the next one, if you dare. My name is Dr. Madeline Carson. I've been a board-certified OB-Tech-Lev GYN for nearly 18 years. Practiced across 3 states, started in upstate New York, did a decade in Georgia, and now I'm in western Colorado. I've worked in both high-risk academic centers and quiet rural hospitals. You see a little bit of everything in this field. Infertility, stillbirth, domestic violence, preeclampsia, miscarriages, postpartum psychosis. You carry all of it with you. But every so often there's a moment that doesn't fit cleanly in the clinical notes. Something that leaves a weight in the air. You can't code it, you can't treat it, you just remember it. This was 6 years ago. Patient name redacted for privacy. Let's call her Rachel. She was 27 G2P1, meaning she'd had 1 prior full-term delivery. Healthy, no chronic issues, married, lived locally. She was about 14 weeks along, there for a routine ultrasound. Nothing high risk on chart, no meds except prenatal vitamins. I wasn't in the room initially. Our ultrasound tech, Marie, was handling the scan. Marie's been with me for years. Steady hands, soft voice, good with nervous patients. She'd just finished scanning the fetal spine and was adjusting angles to measure the nuchal translucency when it happened. Rachel sat up abruptly. Almost robotically, Marie said. Not scared, not panicked, just alert. Then she said, "He's standing behind you." Marie thought Rachel meant her husband, so she glanced toward the door. No one was there. The hallway was quiet. Then Marie looked back, and Rachel's face had gone pale. She blinked a few times and then collapsed. Marie called a code. I was 2 rooms down and got there fast. Rachel was unconscious. No seizure activity. No signs of trauma. Her blood pressure was 58/40, pulse thready. We started an IV and gave a fluid bolus. No signs of a bleed. No abdominal pain. No cramping. Her uterus was soft. Fundal height consistent with gestational age. Fetal heart rate, normal. She came to about 3 minutes later, confused, clammy, tearful. She kept whispering, "He's still here." Let me be clear, from a medical standpoint, vasovagal syncope was our working diagnosis, possibly triggered by anxiety or a hypotensive episode that just didn't present like a typical syncopal prodrome. Labs were clean, no anemia, no dehydration. We held her for observation, and I monitored her personally for the next 4 hours. When I checked in on her again, she was calmer, but she wouldn't make eye contact, just stared out the window. Eventually, I sat down beside her, closed the chart, and asked quietly, "Can you tell me who you saw?" She hesitated. Then slowly she said, "I don't know his name, but I saw him before, when I lost my first baby." Now that caught me off guard. Her chart showed 1 prior delivery, full term, vaginal, healthy child. So I gently pressed, "What loss, Rachel?" That's when she explained, through quiet, halting words, that between her first pregnancy and this one, she had experienced a miscarriage at home, early around 6 weeks. Never reported it, never came in, never told her husband. She said she knew what was happening, and just let it happen. Said she buried the remains herself, under a cedar tree on their property, alone. I asked why she didn't tell anyone. She said she didn't feel worthy of sympathy. It wasn't even a real baby yet, she muttered. But I still felt him leave. Then even more quietly, and I think he came back. I documented her hypotensive episode, ran a full panel, and scheduled a follow-up with maternal fetal medicine just to be thorough. But medically, nothing explained the sheer drop in BP. No placenta previa, no cardiac anomaly, no arrhythmia, nothing. She remained stable the rest of her pregnancy. Her 20-week scan was normal. But she refused to go into that same ultrasound room again. Refused to have Marie do the scan too. though she never said why directly. She just said, "I don't want him to see me again." Rachel delivered a healthy baby boy at 39 weeks, unmedicated vaginal birth. Her husband was at her side the whole time. She didn't speak much during labor, just kept her eyes fixed on the ceiling. When I handed her the baby, she didn't cry, just looked at him and whispered, "You're not alone anymore. I've delivered hundreds, maybe thousands of babies. I've seen trauma and triumph side by side. I've seen postpartum hemorrhage, uterine rupture, even stillbirths that have broken the strongest of families. But this one stays with me, because the body can lie down, faint, seize, bleed. But when a woman looks past you, and says someone is standing behind you, and that someone might be the soul she lost, well, I don't put that in the chart, but I remember it. Every time I step into that ultrasound room, I still look behind me, just once, out of habit, out of respect. I've been practicing obstetrics and gynecology for over 2 decades. Trained in New York, now settled in a mid-sized teaching hospital in the Midwest. I've delivered over 1,000 babies, high risk, low risk, scheduled C-sections, surprise breech presentations, you name it. But every so often, a case or a room sticks with you in a way you don't entirely expect. For us, that room was room 12. Room 12 is located at the end of the L&D wing, right before the NEQ hallway. Structurally, there's nothing unusual about it. Standard size, adjustable birthing bed, EFM monitor, fetal resuscitation cart in the corridor. It's used for high-risk preterm labor cases, partially because it's the quietest, farthest from foot traffic, and closest to the emergency C-section OR. The first time I noticed something strange wasn't because of any ghost story. It was because my patients, different women, different gestational ages, different ethnic and cultural backgrounds, kept mentioning the same thing, screaming. Not just any screaming, a woman's voice. And I want to be clear, I don't traffic in superstition. I've trained in trauma centers and managed OB code blues. I focus on pathology, pattern recognition, and precision. So when something gets reported more than once, I don't jump to the supernatural. I start by ruling out the environmental variables. The first time I heard it was from a 29-year-old Gravida 2, para 1 at 31 weeks. She came in with preterm contractions, no infection, no bleeding, cervical length slightly shortened, but reassuring NST. She was stabilized with magnesium sulfate and betamethasone, and I planned to observe her overnight. Around 2:40 a.m., she called for the nurse, said she heard a woman screaming, not a typical labor scream, said it sounded panicked. The nurse on shift that night checked every room. L&D was calm. She even poked her head into PACU. Nothing. At morning rounds, the patient told me. She kept yelling, "Don't push yet, don't push yet." She swore the voice came from just outside the bathroom door. We chalked it up to anxiety and interrupted sleep. I noted it in the chart, under possible auditory hallucination, due to magnesium sulfate. We see that sometimes, but then it happened again, and again. Over the next 18 months, 6 different patients, ranging from 19 to 42 years old, all admitted to room 12, for various preterm complications, reported hearing a woman scream. 4 of them used almost identical phrasing. She said, "Don't push yet." The night charge nurse, an old school L&D veteran named Jeanette, pulled me aside after the 4th report and said, "I know you're a man of science, doctor, but I've been here long enough to tell when something's off. That room gives people something." I asked for a facilities check. HVAC was fine, no mechanical issues, intercom system disconnected years ago. We even considered whether someone from another unit was playing a prank. We pulled the audio feed from the corridor camera. Dead silent. That's when I started going back through old mortality logs. Room 12, 6 years ago, had been the site of an emergency crash after a uterine rupture during a VBAC attempt. The patient was a 36-year-old with a previous C-section attempting a trial of labor. Her OB at the time noted decelerations just minutes before she coded. The rupture tore through the uterine wall into the broad ligament. They got the baby out, APJs 4 and 7, but the mother never regained consciousness. Massive hemorrhage. X-lap couldn't save her. It was documented meticulously. Time of rupture, units of blood, CPR duration. Even the anesthesiologist's note mentioned hearing her say, moments before she lost consciousness, "Don't let me push yet." The irony of it stuck with me. She had known something wasn't right. I'm not saying I believe in hauntings. I'm saying the human body remembers trauma, and sometimes maybe so does the room. We eventually stopped using room 12 for high-risk preterms, moved them closer to central monitoring, relegated 12 to postpartum overflow or med-surg recovery. Since then, no screaming. But here's the part I still can't explain. A nursing student doing her OB rotation once asked why we didn't use room 12 for laboring mothers anymore. I gave her the clinical answer. She nodded and said, "Good. I thought I heard someone crying in there last night." She wasn't on mag, she wasn't postpartum, she wasn't even on that side of the floor, just walking by. I've practiced OB at GYN long enough to know that pregnancy is as much an emotional journey as it is a medical one. We follow the labs, the scans, the vitals, but the patients. They follow instincts, dreams, and feelings we often dismiss because they don't fit inside a clinical chart. I used to be skeptical of those things until I met Camille. Camille was a 34-year-old first-time mother, healthy, educated, married, and well-informed. She came to us at 9 weeks gestation for initial prenatal labs and dating ultrasound. Everything was normal. Crown rump length matched LMP. No abnormalities. A textbook first trimester. She was unusually calm, the kind of patient who brought a notebook but never needed to open it. At 16 weeks, we offered a genetic screening panel, and she opted in. Results were negative across the board. No markers for trisomy, neural tube defects, or sex chromosome anomalies. She was relieved, of course, but not surprised. When we moved to the 20-week anatomy scan, things took a slightly odd turn. The sonographer marked male on the scan, very clearly. There was no ambiguity. The classic turtle sign was visible. Umbilical cord was distinct. No shadowing. The tech printed 3 images, and I confirmed the call myself. We told Camille, "You're having a boy." She smiled, but not the way most patients do when they hear the sex of their baby. It was polite, not excited. She simply said, "That's strange. I keep dreaming about a girl." I asked if she meant girl in a metaphorical way. Sometimes patients interpret pregnancy symbolically, but she shook her head. "No. Same dream. 3 times so far. She's maybe 6 years old. Curly brown hair, brown eyes, wearing a yellow dress. She calls me mama, and she always says, 'I knew you'd find me.'" We documented it as anecdotal, moved on with routine monitoring. But here's where it got stranger. At 24 weeks, during a follow-up scan to monitor a mild low-lying placenta, male was again confirmed. 3 new images, different sonographer, clear fetal genitalia, no ambiguity. Still, Camille brought in a yellow baby dress. She said was for the dream. Her husband laughed about it, said, "She's convinced we're having a girl even though the science says otherwise." He wasn't dismissive, just amused. By 28 weeks, I noticed she stopped referring to the baby as he or him. She'd say things like, "The baby is active," or "They kick a lot at night." It's not uncommon, especially in patients who are non-binary or private. But in this case, she was reverting to neutral terms, despite knowing the baby had been scanned 4 times now, all reading male. At 36 weeks, we did a final growth scan, male, no question. Her OB record reflected it. Even the NICU prep sheet said, "Expected male infant." But on a quiet Tuesday morning, at 39 weeks and 2 days, Camille came into L&D with mild contractions. We admitted her around 8:40 a.m. By noon she was fully dilated. No complications, no decels. She pushed for 22 minutes, and delivered a healthy, screaming, full-term baby girl, no question. Female genitalia, typical newborn phenotype, Agar's 8 and 9. No signs of ambiguous genitalia. Pediatric team assessed within minutes, confirmed female. Brown eyes, curly hair. Camille held her close, and whispered something that made 2 of my nurses pause. "There you are. I told them you were a girl." Her husband was stunned. Not upset, just speechless. He kept saying, "But, how? All the scans." We rechecked the chart, 5 ultrasounds, 4 different sonographers, 1 board-certified radiologist, all read male. We sent out karyotyping, XX, no evidence of mosaicism, no signs of congenital adrenal hyperplasia, no DSD, disorder of sex development, no genital ambiguity. Every test said girl. Every scan had said boy. I double-checked the ultrasound images myself, post-delivery. And yes, They still showed what appeared to be male genitalia. Not cord shadow. Not poor imaging. Textbook. The radiologist who had signed off on the anatomy scan reviewed it again and said something I'll never forget. If I saw this again tomorrow, I'd still say male. I don't get it. To this day we don't have an answer. There was no data error, no swap charts, no twin resorption, and this wasn't some 50/50ths call. These were high-resolution transabdominal scans performed at a well-equipped hospital with credentialed staff. Camille named her daughter Isla. At her 6-week postpartum visit, she brought Isla in wearing a yellow dress, brown eyes, curly hair, just like the dream. She smiled at me and said, "Sometimes, Dr. Randall, science just hasn't caught up yet. I'm still a scientist. I still follow the data. But every so often, I remember Isla, and I remind myself that not everything about this field can be measured in pixels or blood panels. Some things, rare things, just are." Thank you so much for watching and being part of this growing community. Your support means the world to us, and it's what keeps these creepy, fascinating, and sometimes comforting stories alive. We'd love to hear from you. If you've experienced something eerie, unexplained, or deeply moving, feel free to share your own story in the comments below. You never know, your story might be the next one featured. And if you haven't already, don't forget to subscribe, like, and share to help keep the chills coming. We couldn't do this without you. See you in the next one.